Hello, all. Welcome and thank you so much for joining us today. We're right on the hour, so I'm going to give it just another minute here to let some more folks join in. But we are so glad to have you joining us today to talk about relying on rural resilience. A little bit of a tongue twister, but also really important topic. Thank you again to all of you joining us today. My name is Brianna Routh, and I am a Food and Family Extension Specialist with Montana State University. I am a part of a wonderful group of researchers and extension faculty that join together to talk about all things rural, especially thinking about rural resilience as a part of a multi-state hatch project. And today, we are more than thrilled to be able to continue our series, Relying on Rural Resilience, where we can share some of the research that we've been doing as a part of our multi-state collaborative, as well as with individual teams across the country in thinking about rural communities. And we also get to hear from you as rural health professionals working in the communities and seeing how we can put research into action. Research is a wonderful thing, but unless it turns into action, it can't have nearly the level of impact on our communities. So we're really trying to take this great information from the research and translate it into a way that might be meaningful or impactful in your work. And we can't do that alone. We must do that with you. So again, our presentations today, if this is your first time joining a Relying on Rural Resilience webinar series, we'll have a brief presentation from our presenters, who I'll introduce in a moment, and then we will go into breakout rooms where we'll have an opportunity to talk with each other around some of the ways that we might use this research to inform our practice. After participating in this webinar, I will follow up with all of those of you who have registered and share this brief presentation, as well as some of the resources that are mentioned today and a handout that will hopefully help guide you as you think about how to use this in your future community work as we move into the future. So without further ado, I'd like to take a moment to thank and welcome our esteemed presenters today as they talk about engaging rural Latinx immigrant families in health outreach. Today we have with us Dr. Kimberly Greeter, as well as Rosario Garcia Fino. And with that, I will turn it over to you to share a little bit more with us around the work that you've been doing.
Okay. Well, thank you, Brianna. I'm Kim Greeter with Iowa State University, and joining me today is Rosario Garcia Fino, who is a community partner who's conducted research and outreach with myself and several other extension staff in the state of Iowa, and several other community partners. So there we go. Today, as Brianna said, we're going to share some highlights, and it's simply highlights. It's not all of our findings, it's just some highlights from two particular projects, the Rural Iowa Latinx Family Health Project and Abriendos Caminos. We'll share some of the highlights of the findings, some of the lessons that we've learned, and then as Brianna mentioned, later we're going to give you a chance in breakout groups to talk about some of the things that you heard us share that you might try or that you have tried, or other strategies you have to engage Latinx immigrant and other immigrant families in your communities. So I also want to note that the findings that we're sharing is not just Rosario and I. It's so much bigger than us. There's been a team of numerous people, as you can see on the screen, that have been involved, from undergraduate, graduate students, many of them who are now in postdocs, faculty extension roles around the country, extension staff in here in Iowa are integral to these projects, and other faculty at Iowa State, and some funding that we received over the years to be able to conduct the research and outreach that we're going to share. So the two projects that I mentioned, you can see on the screen, we're going to share highlights around these specific topics. So the Rural Iowa Latinx Project, we've been doing this project in Iowa since 2011. It's a longitudinal study, And as you can see, there's numerous women across 6 Iowa communities who've been part of this study. And the large majority of the women, almost all of the women, were not born in the United States. They were born in Latin American countries. To enroll in this study, they had to have at least 185% of poverty or below. They had to have at least one child who was age 12 or under, and they had to live in one of the study communities. And the interviews were conducted in person by Latino women who lived in these communities, who were bilingual, bicultural, and they had trusting relationships with the Latino community. So they were intentionally selected, invited to serve and be trained as interviewers. And they've continued to interview the families over the years. One topic we're going to talk about today is depression. As many of you know, depression affects not just the individual, but it affects the family. It affects how we function as individuals. It affects how we interact with families. It affects our family's health and well-being. And as a part of that, depression that parents experience, especially mothers, affect outcomes for their children. So we're going to talk a bit about those outcomes that we found from our study. So once again, what we're sharing with finding is what we've learned from the studies we've done. We've learned that depression and not having enough food to eat on a regular basis, chronic food insecurity, has a reciprocal relationship. When you're high food insecure, high depressive symptomology, it's a strong relationship, and vice versa. As you can see on the screen, the different things that we found depression amongst the mothers was related to. Clearly, relationships within their family had a direct link to depression. When mothers played multiple roles, were constantly juggling multiple roles. We found that mothers who were younger in the study had higher levels of depressions, mothers who were single parents. We also found that mothers who had health concerns that limited their ability on a daily basis to carry out their daily activities, or had catastrophic events happen in their lives, such as a car accident, etc., would immobilize them or change their health, was directly related to depression. And many of the things here, as you can see, I'm sure many of you know in your own work. And then we also found specifically for mothers who had children who were eligible to participate in the National School Lunch Program, if they weren't participating, that also was a direct link to depression. What I want to share with you right now is a study of this larger study with the Latinx Family Health Project that we did, and we specifically looked at the relationship between acculturative stress, which can be defined as stress that emerges from conflicts when an individual must adjust to a new culture of the host country. So we looked at the interaction of acculturative stress that the immigrant mothers were experiencing, and then also depression. And how did that interaction affect behaviors in the children? And on this slide, I'll explain the slide a bit. On the bottom is maternal depressive systems. You can see the scale from low to high. And then on the left side, you can see the child internalizing behavior. So those are things inside the child that you may not necessarily see. So think of anxiety would be an example of an internalizing behavior. So on here, you can see the broken line is mothers who had low acculturative stress. The middle line, which is like a series of dot, more gray, is mothers who had moderate acculturative stress. And the dark black solid line is mothers who are experiencing high acculturative stress. Now, what this graph is showing, that mothers who experience high acculturative stress, that stress, when the mothers also have high levels of depressive symptomology, the effect on the children's behavior is quite great. So high anxiety, high internalizing problem behaviors amongst children. Mothers, when you look on the left side of the slide, that mothers who had low depressive symptomology, so there wasn't depression. There's very few signs of depression. When their acculturative stress was also low, that those behaviors of children, internalizing behaviors, weren't high. So what this tells us is that when you have the combination of not just being depressed, but when you're also expressing high levels of a culture distress, their interaction is great and it magnifies the impact on the effects of children. Over the last 4 years, we've been tracking depression amongst the mothers in the Latino Family Health Project. So, as I mentioned, we interview these mothers every year, reach as many as we can. Many times we can't reach some because of cell phone numbers change or they may go back to their home country, etc. But we have about 110 mothers that before COVID started in 2018-19, we measured their depressive symptoms, depressive symptomology. And then we've been following them each year, and you can see up until 2022. So on the screen, when you, for those of you who are familiar with depressive symptomology, we use the CSD-10 scale. And if you have a score of 10 or higher, you're considered at high levels of depressive symptoms. So really clinically depressed. Anything below a 10 is not clinically depressed. But if you're at like a 6 or a 7 or 8, you still have high levels. It's just not clinical. So you can see on average, these are mean scores. On average, across the 110 mothers, there was not high levels of depressive symptoms. However, let's talk about that was the average we just talked about, not everybody's average. You can see before COVID, amongst the 110 mothers, 15.5% had high levels of depressive symptoms. So they're clinically depressed. Over the course of COVID, you can see where that depression increased. So even though on average across the 110 mothers, there was not high levels of depressive symptomology, a quarter or more of the mothers were depressed. Now, this scale might look a little crazy at first, but I'll explain it. The dark blue line is what you saw earlier about the mean levels. I'm sorry, not the dark blue line. The gold line is the mean levels, where on average there's low depressive symptomology. And then what we did is we tried to understand the differences amongst depression amongst the 10 mothers. Well, as you can see, there's a group of mothers that are the dark orange line, and it's like 4.95 is the first point. In 2022, it's 4.38. This group in the dark orange, we're calling the resilient mothers. Before COVID and through COVID, there were 79 out of the 110 mothers that maintained low levels of depressive symptomology. However, there's a group of mothers, and that's the blue line, and those are mothers that started out with low levels of depressive symptoms, but over the course of COVID, those symptoms became more. And by 2022, they're above a score of 10. So they have high levels of depression. And then we have another group of mothers, which is a small group. It's just 4 out of the 110, but they're the gray line. Before COVID, they had very, very high levels of depressive symptomology. Over the course of COVID, their depressive symptoms improved or lessened. However, even at 2022, they still had high levels of depressive symptomology, even though they improved. So out of the 110 mothers, if you take 27 plus 4, 31 out of the 110 maintained or had high levels of depressive symptomology after COVID. Now let's talk about food security. And earlier I mentioned the reciprocal relationship between food insecurity and depressive symptoms. On this scale, the way we're showing food security is a score of 1 or low is considered to be food secure. So on average, before COVID started, mothers were food secure on average across 110. As you can see, they became a little less food secure, but they were still food secure even at time 4. And this is the average mother of the 110. But once again, just like with depressive symptoms, we're not all average. So you can see before COVID, amongst these 110 mothers, a fifth of them had difficulty meeting their food needs. They were food insecure. And over the course of COVID, It grew to 1/3 of the mothers. So even last summer, when we went back to interview those mothers, 1/3 of them were food insecure. So it actually, and some would say we're still in COVID, right? We're still in the pandemic, but it's had a lasting effect. And so the mothers with high depressive symptomology, as you might imagine, also have high levels of food insecurity. We did a qualitative study amongst 110 mothers, and we explored from their perspective and experiences, how did they define health? What does it mean to have good health? We also asked them, what do they do to try to have good health? How do they safeguard their health? And we asked them about some barriers and supports. This is what we learned. And it was a thematic analysis. For the Latina mothers, and the majority of them originated from Mexico. We had others from Guatemala, El Salvador, Cuba, Honduras. The majority of them, as you can see on the screen, being healthy meant you weren't ill. It meant that you never needed to take medicines. You didn't have to go to the doctor. It also meant that you were able to take care of your family on a daily basis. You were able to carry out those activities to keep your family, to safeguard their health. Being healthy also meant it had a lot to do with relationships. And we termed the theme good with family. They felt harmony in their family. There wasn't conflict amongst family relationships. They also described to us that when they felt harmony and unity within their family, it affected their physical health. It affected their bodies, and it helped them feel healthy. So that's how mothers describe for us to be healthy. And what's really important, and Rosario will talk about this later as we talk about implications, but how one perceives things, that's the reality. So as we think about developing programs and interacting with people, especially Latinx and immigrant mothers and other immigrants, we need to learn about what are their perspectives and their experiences and meet them where they're at. And it's so valuable to know their definitions. How did they safeguard their health? Clearly, mothers in the study we did, but the literature also suggests this from other studies, Latinx mothers perceive them, they're the protectors. They safeguard their family's health. That is a primary role many of them have. The mothers talked about intentional consumption. They are very intentional about the foods they buy and they prepare. And they see consumption of food and beverages, of whether they're preparing it or purchasing it, of keeping their family healthy. So they talked about making homemade food, and it was because then they could control what went into it, and they could have fresh ingredients. I remember quotes from several mothers, when we did these interviews, talking about meat they would see in the stores, and it was old and it wasn't healthy. And what they were further describing is when meat was cut up and packaged, they never saw that as being good. It wasn't fresh. And they would talk about preservatives and chemicals in food and how that wasn't good to keep them healthy. Mothers also talked about they preferred activity as a family. So if they were to be physically active, they preferred to do it with their children or with their spouse or their partner or with a friend. And many times they would put their family ahead of them with activity before themselves. So even though they know it might be good for themselves to get physical activity, if they needed to care for their family, or they would rather do something with their family to be active than to do it by themselves. Now, many of the mothers also talked about not having really, when they described their activities, they weren't necessarily real rigorous activities. Some of the mothers had rigorous activities, but many of them, it was more important to be together as a family. Mothers during COVID, but even before COVID, continually when we talked about, they seek information. They're hungry for information. They also want healthcare. They want to have knowledge, strategies, and they will adhere to health advice if they believe it's going to benefit their families. We also learned during our study during the pandemic is that mothers and we had interviewed families before and after fathers as well as mothers before and after COVID. They wanted to be tested. Many of them that were tested, over half of them tested positive. They also wanted to be vaccinated, and they wanted their children to be vaccinated. And I'm talking about the majority. There certainly were those who didn't want to be vaccinated because they were concerned about what was in the vaccine, or their other concern was they had their own health issues and they were afraid about the interactions of the vaccine. Some of the barriers, and I'm not going to go through all of these here, that we've learned from our interviews with families is access to healthcare, affordable, helpful, familiar foods also that, once again, they perceived that were fresh, that would be healthy for their family, that they weren't packaged, they didn't have a lot of preservatives. As far as physical activities, and these were mothers we interviewed in Iowa who were in small rural communities. There was a lack of community spaces to be active. Transportation was a barrier. So mothers walked many places, and some of the parks, broken sidewalks to even get to the park, or you get to the park, but there really wasn't equipment that your children could play in that was age appropriate, etc. Intensive work schedules. This was common amongst mothers, but as well as their partners or their spouses. The manual labor, many of them worked in the agricultural industry and meat packing plants, our food processing plants, in restaurants, worked in hotels, etc. But a lot of physical labor, and they were exhausted because of the work hours, but also the labor. And then also through our interviews, several of the families, the characteristics of their housing affected their health. As you can see, some of the examples in here, mold, how it would affect people's breathing, etc. If during the summer when you don't have an air conditioner that work. Some of the supports that the women talked about is family and friends. And women were especially, their supports were from other women. And it was emotional support from women, advice, strategies they'd hear from other mothers. And also families would share food, childcare, and transportation. Mothers talked about faith is like medicine. And that's the connection to spiritual support, that it was a source of strength to help them deal with challenges in their life, but to persevere and to move forward. And the community, churches were a key source of support. And that was a go-to for many of the families. Government, some of the key aspects that mothers talked about or described that we term as government was where there was a federal health clinic and they could provide free health care for those who were uninsured. And we had mothers in one areas of the state, they would try to catch a ride because many of them didn't have transportation, but they would figure out how to catch a ride to get an hour away to go to the federal health clinic because they could get health care, but also the health care in their local community was not culturally responsive. They did not feel respected by the providers who were providing their, they didn't feel their bodies were respected, they couldn't understand what they were saying, etc. Food assistance certainly was a support. And during the pandemic, interesting, I found very interesting, by 2021, of the 110, or of the participants in the study, 80% of them, either the mother or a spouse of the partner, had received a stimulus check. And that was extremely helpful to pay basic needs for their families. A particular intervention, I'm just going to share highlights. And once again, we're just sharing highlights here, is the Abriendos Caminos. It's a 5 institution project. Iowa joined, as you can see, the other states there. And we conducted this in 2016 through 2018. It was a random control trial. So we had intervention control groups, and we did it in 4 communities across Iowa. Families who participated in the intervention, they participated in a 6-week, 2-hour sessions that was family focused. And the control group received printed materials. So what we found from the intervention is that in the intervention, I should describe a little bit more here, is that it had three major components. Families came as family. So it was parents and their children, but also if there was grandparents, aunts or uncle, whoever defined a family and wanted to come. So we took what we call a whole family approach. We had a nutrition component that really talked about healthful foods, about serving sizes, about sugar, fat intake, et cetera, and trying to look at our traditions and culture and food and bridge them into our eating. And then from there, they did physical activity and family wellness. And so these are some of the outcomes. We saw lower BMI amongst kids. We saw increase in fruit and vegetable intake, as well as vegetables, and a decrease in fast foods. I see that we are running a little short here. So I'm going to flip through the next ones very quickly. But we did blood samples. And what we saw is the intervention had positive effects on cholesterol amongst the families and the HDL and the LDL levels. We also found that when we look at diabetes, the blue line is for pre-diabetics, but the families in the intervention group, their HbA1c decreased, as well as those in the control group had a greater decrease than the intervention, but the intervention did creep. Now, very quickly here, we looked at social support and stress. We measured hair cortisol. As you can see at time 1 and time 2, the blue is the control, the orange is the intervention group. They started out at the same level of cortisol at time 1, and then about 8 months later, time 2, the control group increased in cortisol or stress response, but the intervention group did not increase as great. But when we looked at social support, you can see that the control group decreased social support, the intervention group increased social support. So this leads us to the hypothesis that the intervention in itself could have created a sense of support, which actually helped to buffer stress physiologically amongst the families. So with that, we are now going to move, and Rosario is going to share with us some implications and lessons that we learned. And we will go through these fairly quickly. And Brianna, as she'll mention later, will send out a copy of the presentation as well. So Rosario.
So, hi, my name is Rosario. So, I'm gonna go really quick. So, Kim already talked a little bit about this, but what we wanna do here is to give you like a few key points that are evidence-based after 12 years of doing this research and doing a follow-up with families and how what we found that it could be beneficial when you are implementing a program working with Latinx families. So the first one is that families always want a good health. So mothers, they are always trying to serve as the protector of the family. They always wanna give them a good health. So they wanna be educated. They wanna provide a good information for the family, and they wanna work for them and with them to get a good health. In the next one, we are going to see that the families, immigrant families, not only Latinx families, but all the families, they are having a lot of long hours at the workplace. Not a lot of money, so is in Latin families, we in average, we know that the money that they are getting is between 36,000 a year to 46,000 a year. So it's something that we have to take into consideration when we are also planning all of these programs for them. So it's a lot of discrimination and racism, and they also feel that there are not enough resources for them. So, and those resources could be limited for the immigration status in this country. And they are bringing a lot of trauma, a lot of violence from their countries. So we need to pay attention to this. In the next one, we are going to see that families, they have to survive in the United States. They have to be resourceful. So they are bringing their own culture, their own traditions. So we have to respect this when we are working with them. They develop different core beliefs when they are here, but they are bringing their own when they are coming from their own culture. So we need to take this into consideration when we work with Latinx families and with immigrant families in general. In the next one, we are going to see that uh, Latin families, like other cultures, we are coming from a collectivistic culture versus the individualistic culture that we are used to live here in the United States. So they are thinking in a family as a group. When we think about as a family, taking care of a family, we are thinking about taking care of the kids, parents, grandparents, and uncles, so everybody in the family, and we have to include all of them when we are creating all of these programs for them. So we have to invite them. So and remember that they take decision together. So when they take those decisions, they are gonna say, okay, we are gonna assist to this program or no. So it is something that we have to take into consideration. Not only say, okay, this program is gonna be just for parents and kids. Oh no, we are not gonna go because uh, we are not the abuelos, so the grandparents, they are not invited. So we have to take that into consideration because like grandparents, they mean knowledge in these families. So we need to bring all of these concepts into our own planning program. In the next one, we need to be aware, and this is something really important that we have to highlight this. We need to be aware of our own assumptions, our own bias, stereotypes that we are bringing. So because this can be a barrier when we are working with Latino families. So educate yourself. Um, be aware of your own ideas, your own values, what are you bringing into the table when you are creating these programs. Develop relationship with families and organizations. So they already trust the organization that they are working with. So we have to include them there. And we have to know that if they don't trust us, if they perceive any discrimination, they are not going to go to the program. They are going to say, nope, thank you, bye. That's it. They are not going to show up. So be aware of that. Be aware of your own bias. I think that's the message. That's the main message from this slide. The next one, use a simple language. So all of us, all of Latinos, we are coming from different backgrounds. So if I'm from Mexico, I am from Colombia. But in Colombia, we have different subcultures. In Mexico, they have different subcultures. In all of the cultures, we have different subcultures. So be aware of that, that we have to talk in a simple language because the language barrier is not only Spanish and English. No, it's more than that. So we need to be aware of the level of literacy of the participants. We need to be aware of the health literacy that they have. We have to also be aware about the social and geographical isolation that they are living because they are not living in the community that they grew up. So that's something that we have to be aware when we create these programs. Understanding multiculturalism as a multiculturalism. So we need to engage when we are working with these communities, engaging community leaders. So go to the nonprofit organization. They can be in the committee for the planning to help to plan, implement the program, listen their ideas. So what is important for them in the community? Avoiding collecting unnecessary information, identifying information. So we know that a lot of people that have different papers or documentations in this country. So we need to be aware of that. They are sometimes afraid to come to the programs just because they don't know if we are going to give that information to somebody else and that is going to make them to be in trouble. So avoid collecting unnecessary information is a way of trusting people, and respect confidentiality. And also, when we work with these families, bring the family together. So if we have we have this big plan, okay, this is the activity I'm gonna go and I'm gonna do, but they bring an idea, take that idea into consideration. If they have a game that they wanna play for physical activity, okay, let's go and do it, because they are the experts in their culture. So respecting that is super important. And now we are gonna go to discussion.